If you perform microsclerotherapy for leg spider veins, there is one question you probably ask yourself fairly regularly. Do I need to arrange a duplex ultrasound scan before treating these thread veins? It should have a simple answer, but in my experience, there isn't one. And there's a lot of confusion out there, partly because the major international guidelines do not all say the same thing. In this video, I'm going to take you through what the evidence actually shows, where the key guidelines agree, where they diverge, and what a pragmatic, evidence-based clinical approach looks like. And stay to the end, where I will give you a practical framework you can use in your clinic right now. Let's start with why this is important clinically and practically. Telangiectasias are extremely common, affecting a very large proportion of the general population. Most people who present for treatment are asymptomatic and are seeking cosmetic improvement rather than treatment for venous symptoms. At the same time, duplex ultrasound is not universally available in aesthetic practice, and routine scanning may commit patients to a pathway that can lead to unnecessary intervention. But of course, the opposite is also true. Some patients clearly do need a duplex scan before treatment. The real question is, which patients actually benefit from it? So let's look at what duplex studies actually show in patients with C1 disease. Underlying saphenous incompetence is common. One prospective study found that around 44% of C1 limbs had saphenous incompetence on duplex ultrasound scanning. But there are important caveats. That was a vascular surgery referral cohort, and these referral cohorts will tend to have more patients with hemodynamic disease, so we should be careful about applying that number directly to a general cosmetic and aesthetic vein practice. The Edinburgh vein study also adds some important information. In people with more significant telangiectasia, just over half had no clinical varicose veins, and small saphenous incompetence showed no meaningful association with the amount of telangiectasias present. So reflux is clearly part of the story, but it's not as simple as a one-to-one explanation for every C1 presentation. And that brings us to pathophysiology. A systematic review by Kern concluded that the pathophysiology of telangiectasia is still largely unknown. Reflux may contribute, but it's not the only mechanism. There are arteriovenous microshunts, vessel wall abnormalities, and connective tissue factors that may also play a role. That's important because if the pathophysiology is multifactorial, then treating reflux alone will not reliably solve the telangiectasia problem in every case. So the idea that every spider vein patient has a hemodynamic source must be found and treated before microsclerotherapy is simply not justified and could be an oversimplification. So here is where we have a huge gap in the evidence. At the moment, there is no randomized control trial showing that pretreatment duplex scanning improves microsclerotherapy outcomes. That is the question that really matters, the question that is really important. Not whether reflux exists, not whether duplex scanning can detect it, but whether scanning patients before treatment and dealing with that reflux actually leads to better outcomes. Now, during the 2016 surveillance update of NICE Guideline, CG168, one of the review questions was whether duplex ultrasound assessment improves outcomes after venous intervention. Now, don't get me wrong, duplex ultrasound scan is important in deciding what treatment modality to actually perform, but this was asking a different question. Does duplex scanning before venous treatment lead to better outcomes? For that question, the NICE decision matrix recorded that no relevant evidence was identified. That doesn't mean that duplex is unhelpful. It means that there were no comparative data outcomes to justify changing the guidance on that basis. Now, here are three key pieces of evidence I think are worth considering together. First, the NICE surveillance review did not identify relevant evidence that duplex improves outcomes from venous treatment. Second, the EASI randomized trial showed excellent microsclerotherapy outcomes with 96% physician-assessed improvement, and pre-treatment duplex was not mandatory for entry into that study. Third, the Cochrane review did not find evidence that the results of a duplex scan actually modifies the outcome from sclerotherapy or laser treatment of telangiectasia. Put quite simply, there is no direct evidence from trials that scanning before treatment improves the cosmetic result of microsclerotherapy. And here is where the confusion often comes from, because guidelines do not all say the same thing. The ESVS guideline from 2022 recommends duplex before treating all C1 patients, but that recommendation is level C evidence, which means expert consensus rather than primary outcome data. The UIP guidance from 2024 takes a different view. It says duplex is not required in asymptomatic C1 and should be reserved for symptomatic patients. The SVS, AVF, and AVLS guidance from 2023 is similar. In fact, it goes further. It recommends against routine duplex in asymptomatic C1 patients and explicitly warns about the risk of unnecessary saphenous ablation. The NICE guidance and the surveillance report is a little different again. NICE CG168 is a varicose vein guideline rather than a C1 specific microsclerotherapy guideline. And for that, the surveillance review did not identify evidence that duplex improves venous outcomes. One could argue that if a pre-treatment duplex ultrasound scan for C2 disease does not improve outcome, then why on earth might it improve outcomes for treating C1 disease? So why do the guidelines diverge? The ESVS position is built mainly on logical reasoning and expert consensus, and it goes something like this. Reflux is common, therefore scan for it. I get it. I used to believe myself that duplex scanning was mandatory before treating C1 disease. But there is in this a cause and effect assumption. And another assumption is that treating the reflux before microsclerotherapy leads to better outcomes. By contrast, the UIP and the SVS, AVF, and AVLS documents are more specifically anchored to systematic reviews and to the absence of direct outcome evidence. They focus specifically on microsclerotherapy and C1 disease. That narrower focus makes their recommendations more directly relevant to the patient in front of you when you are considering cosmetic treatment of telangiectasia. That's why, in my opinion, current evidence points towards the selective scanning approach. And here is my practical concern. And it goes like this. A patient attends with cosmetic thread veins and spider veins. A mandatory duplex scan is performed. Asymptomatic saphenous reflux is found, and then there is the clinical pressure to treat the reflux before microsclerotherapy, and before long, a patient who came for cosmetic veins is being steered towards saphenous ablation. This is not a theoretical concern. It is a predictable cascade once scanning becomes routine rather than selective. And that's why the warning in the American guidelines about unnecessary ablation is so important. So what should we actually do in practice? Here is the group where duplex is not routinely required. If the presentation is asymptomatic C1 disease, purely cosmetic, with isolated telangiectasia or reticular veins. no venous symptoms, no palpable or visible varicose veins, no ankle swelling, no skin changes, no history of DVT, no prior venous intervention. If all of those are true, then you don't need to arrange duplex before proceeding. The patient can proceed to microsclerotherapy after a thorough clinical assessment, a history and examination. That's it. No duplex scan. On the flip side, this is the group where duplex should be performed. If the patient has symptoms such as aching, heaviness, throbbing, burning, or night cramps, symptoms that raise the possibility of underlying chronic venous insufficiency. The same applies if there are visible varicose veins in addition to telangiectasia, ankle edema, skin changes such as hyperpigmentation, eczema, venous eczema, lipodermatosclerosis, atrophy blanche, corona phlegmatitica around the medial malleolus, if the patient's had previous intervention, a history of DVT, or telangiectasia resistant to previous courses of microsclerotherapy. In these cases, duplex ultrasound scan is very likely to lead to an intervention that will benefit the patient and improve the results of microsclerotherapy. There is one indication that deserves special emphasis, and that is in cases where the telangiectasia have been resistant to previous microsclerotherapy. And there's a small series of patients reported with telangiectasia which have been resistant to sclerotherapy, and 65% of those had a connection to a deeper or perforating vessel on duplex, and ultrasound-guided treatment of these feeding vessels achieved clearance. So if a patient has already had 2 or more courses of sclerotherapy with poor results, duplex is strongly indicated before you treat further. This is not routine scanning for everyone. This is targeted scanning in a group where management is likely to change. One final clinical point that I think often gets lost. If you do scan and you find reflux, that doesn't automatically mean it has to be treated before microsclerotherapy. The UIP guideline is very clear here. If reflux affects an area that is not involved with C1 disease, elimination of that reflux may not be necessary, and a shared decision-making approach with your patient should be used. So the key question is whether that reflux is anatomically related to the area you are trying to treat, and whether it is actually symptomatic and hemodynamically relevant. Incidental asymptomatic reflux is not the same thing as clinically important reflux. And that is where shared decision-making becomes essential. If reflux is identified, explain the clinical finding clearly and honestly. Clarify whether it is likely to be symptomatic and relevant. Explain that not all detected reflux requires treatment before microsclerotherapy, and talk through the options. Treat reflux first. Proceed with microsclerotherapy or monitor, and remember that a patient who came for cosmetic thread veins may not wish to proceed with saphenous ablation. That preference should be documented along with the agreed plan. Let me summarize the key clinical points. There is no primary trial evidence that pretreatment duplex improves microsclerotherapy outcomes. The UIP 2024 and the ESVS, AVF, and AVLS 2023 guidance recommend against routine scanning in asymptomatic C1 patients, whereas the ESVS 2022 recommendation for universal duplex rests on level C evidence only. The pathophysiology of telangiectasia is multifactorial. So reflux is not the sole driver of the development of telangiectasia. A pragmatic clinical approach, in my view, is the selective use of duplex, guided by symptoms, signs, the prior treatment history, and clinical suspicion. Treatment resistance is a specific, strong indication for duplex, and when reflux is found, the decision should be individualized because not all detective reflux requires ablation first. There's a real need here for more research, a prospective randomized trial comparing microsclerotherapy with and without prior reflux treatment. I've written a full evidence review on this question at Vein Care Academy, and I'll put a link in the description box below. If this has been helpful, please give it a thumbs up and a like. It really does help my channel. And consider subscribing for future videos and clinical updates. That way you won't miss my next video. My name's Dr. Haroun Gajraj. Thank you for watching.